Are we online now? Are we broadcasting?
Yes, Prof.
Okay. Okay, so we will start in 5 minutes. We welcome those who joined, and we will start in 4 to 5 minutes. Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. We welcome you all we'll start now. We welcome you in this webinar workshop. I'm Dr. Ahmed Bahamam from King Saud University in Riyadh, the University Sleep Disorders Center. I'll share our initial welcoming. We welcome you all in this webinar workshop, which is timely, and we hope that it provides the expectation for the attendees. We have good number of registrants so far, almost 500, and we hope that more will register as we start and go through. If we reach 1,000 in the plan we have, the broadcasting will go live on Facebook and Instagram. Meanwhile, if we are less than 1,000, we'll be through the registration. You have probably seen the poster We welcome you all. The objectives of this webinar is to present and propagate principles and guidelines for resuming normal or near normal functioning of sleep medicine services, whether in-house, in-lab, or home sleep apnea testing. We'll cover all of that during this ongoing COVID-19 pandemic, which is up and down, and which also may last for a few more months to come. Also resuming both diagnostic and therapeutic, whether in-house or remotely. We'll talk about also remote monitoring, about virtual clinics, and how to assess the situation in your country or your city. Are you ready to start or not yet? In this workshop, we target all those health allied who are interested in sleep medicine, mainly sleep medicine physicians, sleep technologists, respiratory therapists, nurses who do sleep studies, physicians who are interested in sleep study or who are doing home sleep studies, students with interest in sleep medicine and sleep technology, and researchers in sleep medicine and sleep science, and all allied health professionals who have interest in this field. Basically, in this webinar workshop, we will cover COVID-19 mitigation strategies for sleep medicine services. We'll talk about policies and procedures. Then we'll have a talk about home sleep apnea testing, a leeway during pandemic. Then we'll spend some time talking about the management of aerosol during non-invasive ventilation for patients with sleep disordered breathing. And this should be applied whether you titrate positive airway pressure in lab or at home. And we have a very important lecture about remote monitoring and adjustment of the positive airway devices of patients while at home. We know that the home monitoring or remote monitoring now is available in some countries, but not others. It needs to get approved by the local authorities to send data outside the country and so on. So some countries, they have that, some they don't. In Saudi Arabia, Philips, they have the Saudi approval, but the service has not started yet. And we may have audience here from different countries. Then we'll go to the technicality about how to disinfect different diagnostic equipment and therapeutic equipment as well. And then we'll have a short video about disinfection of equipment. We'll try to have panel discussion after each, like the first 2 lectures, then after 3 lectures or 4 lectures. If the speaker finishes early, then we are going to have 1 or 2 questions. By the end of this webinar workshop, we expect that the participant will be able to ensure resuming sleep medicine services despite COVID-19 pandemic, implement best practice guidelines based on what have been published so far, and triage the patients for sleep medicine services, practice and propagate epidemiological updates, how to decide the risk in your community or your city or country, practice and propagate infection control guidelines, practice and propagate safe handling of equipment for sleep diagnostic or therapeutic equipment, and finally disinfection protocols for different equipments. I will show you that. The speakers, I'll be talking with my colleagues. I'm Ahmed Bahamam, Professor of Respiratory and Sleep Medicine at King Saud University in Riyadh. From the University Sleep Disorder Centers, we have Dr. Saleh Al-Eisi and Dr. Abdulraouf Berzada. From the technology part, we have Mr. Abbas Sheikh and Mrs. Fatima Al-Ahmed, who will also be presenting the disinfection. Philips are participating with us in this workshop and other workshops that we are doing. We are glad to have with us Dr. Faisal Abdelnabi from Paris, France, who have been a good asset always to us in different workshops. And this time also we have with us Engineer Anas Naji from Dubai. And the panelists at the end for discussion, we have senior sleep technologists who will be with us in all discussions. If we have some technical issues, we have Mr. Mashni Saeed from King Faisal Special Hospital and Research Center at Jeddah, in Jeddah. And from the University Sleep Disorder Center, Mrs. Mariam Chakwan and Mrs. Smith George. As you know, in webinars, usually we don't have direct interaction. Please write your questions, we'll read it, and in the panel discussion, or if the speaker finishes early, we'll try to get a few questions to answer. And as we go on, we'll see also, we'll recommend some publications that you can download from the internet to help you with that. So without further ado, we'll start with the first talk, which will be COVID-19 medication strategies for sleep medicine services, policies and procedure by Dr. Abdelraouf Birzada. I'll stop sharing here so Dr. Abdelraouf can start. I'd like all the speakers, please, to put their mic on the mute so there'll be no echo, and also to time themselves so we have enough time for questions and answers. Dr. Abdelraouf, you may start. Abdelraouf, we can't hear you.
Outline of my talk includes...
Okay, yeah, I think you were in the mute. Okay,
yes,
that's fine.
I'm sorry
Please,
about that.
speakers, don't forget to open the mic when you start talking.
Outline of my talk will be the introduction, objectives, general considerations. In general considerations, we'll have screening, infection control, epidemiological leads. Then we'll have approach to reopening of sleep disorder centers. Finally, summary. As we all know, COVID-19 emerged as sporadic cases from Wuhan, China, gradually spread across all continents. Healthcare systems were pushed to the wall. Diversion of almost all services from elective to acute care took place. And with it, we had new demands. New demands were met with teleconsultations and courier services. Teleconsultations provided online and virtual consultations, telephonic consultations, and follow-ups. Courier services provided medications, prescriptions, and devices. These new portals, like teleconsultation and courier services, these aided clinical services did provide some mitigation. But most important thing, sleep studies remained suspended. Now question arises, do we need full sleep medicine services? Answer is yes. Since treatment of sleep disorder breathing has an impact even on COVID-19 outcomes, high-risk patients cannot wait. The pandemic is taking a protracted and unpredictable course. As you all know, we have been fighting it for more than 4 months now, and we don't know where from here it will take us. So we came up with our aims and objectives. Ensuring and supporting efforts for gradual and safe resumption of sleep medicine services to pre-pandemic level, implementing best practice guidelines and protocols for infection prevention and control, minimizing the exposure of patients and healthcare workers to the virus, ensuring judicious use of healthcare resources, maintaining patient access to care and continuity of care to avoid ambiguities and unnecessary consultations and attendance in clinics. We have to promote public health and safety, and we have to address any concerns about it. Come to general considerations and background preparations. This is our master reference. It is reopening of sleep medicine services in conundrum of ongoing COVID-19 pandemic, has come in sleep and vigilance. You can access the content through this DOI. It is available online. So we come to the factors that determine the resuming the services. First thing is the preparedness of the sleep disorder center. And second is epidemiological status of the city, province, or state. So what do we mean by the centered preparedness? Centered preparedness encompasses healthcare resources and logistics, staff education and training to provide optimal services without compromising infectious control guidelines. The first step in central preparedness is screening. Screening of staff, screening of patients, and screening with point of contact testing. Screening of staff involves that healthcare personnel and office staff must be routinely screened. We have to screen all staff for COVID-19 symptoms. This can be done by giving them a questionnaire every day. They should be encouraged to volunteer any information about the symptoms and should take temperature checks twice daily. Any staff with symptoms should be sent home. We have to practice staff rationing. By practicing staff rationing, we leave a room for sickness and quarantine deficit, which is very common during pandemic days. We have to implement sick leave policies that are non-punitive, just flexible and consistent with public health policies and demands.
Dr. Raouf, some they say that your voice is low. If you can raise your voice, please.
Sure. We have to allow all ill personnel to stay home and encourage the staff not to report to work when they are ill. About the patient screening, once we do the patient screening, we define the patients. We identify our patients as status unknown, presumed negative, self-quarantined, presumed positive, and positive. Then we come to patient screening protocols. Patient screening protocols has two parts: screening prior to appointment and screening at the time of appointment. Pre-screening prior to the appointment, we use phone calls, patient portals, virtual meetings or online assessment tools, which are to be delivered online and retrieved online. Through these tools, we review COVID-19 symptoms like fever, cough, shortness of breath. We review COVID-19 status and reschedule patients who have symptoms or positive or pending COVID-19 tests. Then we come to the screening at the time of the appointment. At the time of appointment, we make a temperature check of all our patients, again screen the patients for COVID-19 symptoms, and see the test status upon arrival at the facility. All patients with symptoms or positive or pending COVID-19 tests are to be rescheduled. Then we come to screening with the point of contact testing. This depends on the logistics of the center, whether we can afford it to do it or not. Whenever adequate COVID-19 diagnostic testing is available, patients should be tested in a reasonable time frame before the appointment. Reasonable time frame here means that it should be done at a time where it is reliable, like a patient coming today to the center should have test around at the most 72 hours before, and swabbing should be done so that test is available at the time of arrival. Another thing is vigilance testing, which is a plausible step whenever it is requisite and whenever it is possible. Healthcare personnel, cleaning staff, other hospital staff, including the office, should be regularly screened with diagnostic tests when COVID-19 testing is available and logistically possible. Then we come to our next step, which is infection control. We have to ensure that the designated staff member, usually a clinic coordinator, is responsible for regularly monitoring COVID-19 updates from the state, local health departments, and hospital managerial body. All in-person visits should be minimized by utilizing telemedicine or other online portals for pre-procedure counseling and education, screening as well as to obtain an informed consent. Within the center, physical distancing is to be maintained by spacing the chairs around 1 to 2 meters apart, minimizing the waiting time in the waiting area, and keeping patient volume low. We can ask the patients not to wait at the center, but they can wait in the parking lots. Important thing is all these instructions should be passed to the patients beforehand through telemedicine portals. So once they arrive at the facility, they know what they have to follow, how they have to do things. Patient attendance and visitors ought to be minimized. Best is to be avoided. If we need any translation services, we should consider using remote access services. We had to place visual alert posters, placards about the COVID-19 signs and symptoms, hand hygiene, respiratory hygiene, cough etiquettes at entrances at in the strategic places. We have to ensure hygiene supplies are adequate and accessible. We have to have staff should follow infectious disease protocols and procedures for cleaning and inspecting all patient-related equipment. For cleaning reusable equipment, we have to follow manufacturer guidelines. Infectious control guidelines should be also considered. For contact surfaces like bedposts, tables, etc., infectious control guidelines are to be followed. I'll not go into detail. We'll have a talk about it in the coming session. Now we'll talk about the personal protective equipment. This is a part of center preparedness. We have to monitor actively and secure PPE supplies. In addition to that, we have to practice judicious use of PPEs. We have to ensure staff is trained in donning and doffing of PPEs, and they are educated about indications of use. Clinicians, staff, and the patients should use surgical masks in the center. All aerosol generating procedures, such as PAP titration, should be done with great caution. Staff doing the titration should utilize appropriate PPEs, such as N95 respirators, gloves, face shields. It's recommended before using N95 respirators, we should have a fit test. Now we'll talk about the epidemiological inputs. Epidemiological inputs tell us about the disease volume of a particular area or a place or a province. So areas are divided into three divisions. First is high endemicity, like here we have high community transmission. Then we have sporadic cases or sporadic clusters. Then we have low endemicity, where community transmission is almost absent. Now we have center preparedness and we have epidemiological leads. Then we take on a step-wide approach to reopening of sleep disorder centers amid COVID-19 pandemic. First message is all sleep studies for patients who are COVID-19 positive or COVID-19 suspect, patients belonging to high endemic areas with high community transmission, we have to suspend, we have to reschedule them. However, in high endemicity areas, we can consider doing sleep studies in case of emergencies. Like we have a critically ill patients with sleep disorder breathing. But we have to commence doing in these emergent cases only after careful COVID-19 screening and a thorough consideration of potential benefits and risks. There is another way suggested by American Thoracic Society that we follow the epidemiological leads. Once we come across a downward trajectory for around 14 days period with the usual testing and the usual protocols, we can resume gradually sleep studies. They have suggested a stepwise pattern or stepwise algorithm. After taking leads from the epidemiological inputs, the first step is doing home sleep apnea testing. These can be complemented with home titration studies. Once we run this smoothly and disease volume is coming down, we can go for diagnostic in-house testing after patient prioritization. Here, prioritization means that we prioritize the patients who need an urgent or emergent polysomnographies, like critically ill, sleep disorder breathing, like narcolepsies, like RIM behavior disorder, who are at a risk of injuries. After running this phase smoothly, we can go to the next phase, which is in-house diagnostic and titration studies. For sporadic areas, we postpone and reschedule all sleep studies for patients who are COVID-19 positive or COVID-19 suspect. Then we do the patient segregation. We postpone all polysomnographies, diagnostic as well as therapeutic, in patients who are at high risk of getting COVID-19 illness, like older adults, pregnant women, patients with underlying cardiac, renal, metabolic disorders, or those who are immunocompromised. Besides pediatric patients, because pediatric patients, they are at usually there is a high chance of having asymptomatic COVID-19 carrier in pediatric age group. There should be no penalties for patient cancellations and missed appointments related to any respiratory illness. Rescheduling should be readily available to encourage patients to declare symptoms. Because at most of the centers, what we know, appointments are given with a waiting period of 6 months, sometimes even more. So patients are very reluctant to miss an appointment for sleep studies. All patients should have symptom screening through phone before arrival and upon arrival in the center. Wherever testing for COVID-19 infection is logistically feasible, all patients can be tested in reasonable time frame. All inpatient routine appointments should be postponed and rescheduled. AASM recommends, and many other societies endorse that sleep clinics should consider deferring all elective in-person sleep clinic appointments. Telemedicine contact is encouraged to avoid any loss of follow-up and for patient confidence. For emergency or unavoidable in-person visits, infectious control protocols and guidelines are to be followed. I recommended PPE to be used. However, if we come across this kind of setting where we have a patient who had during past 2 weeks traveled or the residential high epidemic area or a contact with COVID-19 infected patient, contact history with febrile patients or subjects with respiratory tract symptoms from high and or cluster outbreak areas, or a patient reports fever or respiratory tract symptoms, we have to reschedule. Another important point is the management of errors during the sleep study. Due to high risk hospitalization, titration studies and split night studies should be postponed except highly emergent conditions. In a setting of suspected or confirmed case of COVID-19, infectious disease protocol of isolation in negative pressure room, preferably with the anteroom, and PPE for attending staff are required. PPE of attending staff during titration is always mandatory. Due to high risk of aerosolization, PAP devices should never be operated in clinical room, even for demonstration. We can go through this paper which is about the management of aerosols. And we'll have a comprehensive talk about aerosol management coming after this lecture. Now I'm coming to a stepwise approach. Once we have a central preparedness, we have epidemiological leads, how to do stepwise manner. Once we have divided areas in high endemicity, sporadic, and low disease endemicities, in sporadic areas, we do the risk evaluation, as I talked about. High-risk patients, we club them with high endemicity areas, and low risk, we keep separate. For low disease endemicity, we can go for polysomnography with or without pap titration. However, if our patients from low disease endemicity area have positive history of contact with COVID-19 or have a history of travel or have symptoms, we have to postpone and schedule.
Dr. Raouf, you need to raise your voice, please.
Yes. The low risk subgroup of sporadic group, if they have any positive history of contact or COVID-19 or travel or symptoms, they need to be postponed and rescheduled. Or we can take them for diagnostic polysomnography only. On the other hand, we have high endemicity group where we can take emergency cases, which is already clubbed with high risk from the sporadic. If patient is emergent and there are risk and benefit ratio in favor of doing the polysomnography, we can go for polysomnography, or otherwise we have to postpone and reschedule. However, if any of these patients has positive history of contact with COVID-19 or travel or symptoms, we have to postpone and reschedule. Now we are coming to the take-home message. We have to follow the day-to-day epidemiological reports, and we have to follow the infection control guidelines. Any patient belonging to high endemic area where there is a high community transmission, and patients who have positive COVID test or who are symptomatic for COVID-19, they are to be suspended and rescheduled. Thank you very much.
Thank you, Dr. Raouf, and thank you for keeping us on time. And there have been few questions about CME. Unfortunately, CME needs to be planned ahead of time, 5-6 weeks before, and this was arranged, this workshop, in 3 weeks because of the need, because everything is opening now. So it was not feasible to take CME. Again, for the attendance certificate, the system does not allow that. So I cannot promise you for that, but we will see if we can do, but I cannot promise you that we will have the certificate. We'll do our best. Dr. Raouf will take one question here, then we'll have a break. They ask, like, if a patient was diagnosed to have sleep apnea, they say, will I be encouraged, will I encourage the patient to use CPAP at home? Will you encourage the patient to use CPAP at home?
Actually, we'll have a separate talk about the use of CPAP at home. But what is recommended, as long as we can, if it is to be used in urgency, like in patients who have OHS or who retain CO2 to some other cause, they can continue to use at home. However, they should be isolated at home. So that, because whenever we use a PAP device, there's a risk of aerosolization. And we also know that there are many patients of COVID who are asymptomatic. So we have to take precautions, like he should be isolated at home and they can carry on using PAP device as long as they need it. But routine OSA patients who can spare some time to use CPAP device can wait.
Okay.
But it is rather an individual choice in them than recommendation.
There have been debate between specialists about whether to use or not to use these days. But I would say that if a patient is asymptomatic, has no contact with COVID-19 patient, asymptomatic, then probably they can use their device. But if there are contact or any risk, or they have been put in quarantine until the results are there, they should use it in a separate room, probably. There is a question here, we'll take one more question, about like how did you reach the, I think they mean the categorization, the 5 categories of classification of patients. I think they say, can you identify how the 5 patient classification treated in relation to BSG studied identified? Or they meant like known case or unknown case of COVID-19?
No, for all, if a patient is known case of COVID-19.
Please raise your voice.
If a patient is known COVID-19, we don't take him for the sleep study.
No, but
whatever area he belongs
about
to.
The 5 categories. The 5 categories, was this from the American Academy of Sleep Medicine?
Of course, yes. This is from the American Academy of Sleep Medicine and CDC.
Okay, so they categorize patient into 5 categories.
Yes, this is
yeah. So this is like international standard categorization of patients.
Yes.
Okay. Okay. I encourage the attendees to write questions. We now will go to the next talk. Probably we'll have 2 more talks. Then we'll have panel discussion for 15 minutes. So the next talk will be, I think it's my talk. Okay. Okay. Can you see it now, all?
Yes. Yes, it's clear.
Okay. So I will time myself as well. Okay. This talk will be about home sleep apnea testing, which is popular to start with, but these days it's more popular as a leeway during COVID-19 pandemic. So the objectives here to discuss the need of home sleep apnea testing during the COVID-19 pandemic, the utility of home sleep apnea testing during this pandemic. I mean, we know it is it's a good alternative in usual days, but these days probably it is more important. The identification of patient in whom home sleep apnea testing is likely to be successful, and then the assertion of staff and patient safety during apnea home testing, the importance of cleaning the equipment, the utility of unattended auto CPAP titration. Just we'll talk about the evidence. Then in the lecture about telemonitoring, we'll have more details and we'll show you some waves of real patients, how it looks, and how do you know by the telemonitoring if they have leak or if they are mouth breather. That will go into details of that in a separate lecture. So we'll have introduction. We'll talk briefly about types of home sleep apnea testing, indication, contraindication, and limitations, the utility in COVID-19. So when you say home sleep apnea testing, it refers to doing a diagnostic sleep study for sleep apnea only outside the sleep laboratories or sleep centers. And typically it's a portable device that the patient, him or herself, can connect. You don't need to do it, or no technician need to do that. Has limited accessories and usually come with a brochure or link video, educational video. And the patient can wear it at home and turn it on and off. It's very simple. So why do we need home sleep apnea testing? To reduce the need for expensive time and labor-consuming laboratory testing. And during these days of COVID-19, it's more important because admitting patients to the hospitals become more difficult. And also to increase the availability of diagnosis, cut on the waiting list. And it's more convenient for the patient, definitely, especially these days, for both staff, medical staff, and patients. As you know, there are 4 levels or 4 types of portable or home sleep apnea testing that have been bought in 1994 when the American Academy of Sleep Medicine was called at that time American Sleep Disorder Association. People still follow this. They propose new types, but was not practical, so people are back to this old system. Type 1, which is the in-house, in lab, and this is we will not discuss here. Type 2 It's a comprehensive, it has neurocardiopulmonary monitoring. It's like type 1, but it is unattended. Again, this is used mainly for research. It's not practical to use with the patient because it has EEG and EMG, which is difficult for the patient to fix. When we talk about home sleep apnea testing, we mean mainly level 3 or type 3, which is usually 4 or channels. It has, we'll discuss in more details, airflow, effort, oximetry, they have ECG, they have other things as well, and it is unattended than at home. And type 4, which is called single or dual, 2 channels means. It's also a reasonable alternative, but not as good as level 3, because usually we don't effort it, so we cannot tell if it is obstructive or central apnea. So when we talk about level 3, as we said, at least 4 channels, 1 or 2 channels of respiratory movement, 1 nasal flow, and 1 oxygen saturation. And then you may have other things like heart rate, body position. This can be all added to it. The problem with type 3, you have to know if you are going to do home sleep studies during this COVID-19 pandemic, it does not record signals that are important to score hypopneas. So if we score hypopneas by desaturation and or arousals, you don't have EEG, so you cannot score arousal. So by this way, you will diagnose hypopneas. So this is something that you have to keep in mind. It has also other problems that we'll talk about them in the coming slides, because you don't have EEG, you cannot tell if this is REM-related OSA or not. Because if it is REM-related, happening only in REM, which is 20 to 25%, probably 10% in some patients with sleep apnea, then when you take it for the whole recording period, it will be diluted and appear as normal AHI. Again, as we don't have EEG, we cannot recall total sleep time. So we divide the number of apneas and hypopneas by time embedded by the total recording time. And this will dilute the number of apneas and hypopneas. So home sleep apnea testing tends to underestimate the actual AHI. This is an example of level 3, where we see the nasal cannula, the respiratory effort, and the pulse oximeter. You can put other things and more than this. This is a newer model which has flow, snoring. The American Academy say you need to have snoring, it's good. Thoracic effort, saturation, heart rate, body position, and with sonography as well. So this is a type 3, a recent model which has more signals. And this is the raw signal, how it looks. It's recommended by the American Academy to be scored manually by an expert, not by the machine, because auto scoring still is not approved. Though there are some studies saying that it is good, but still is not an universally accepted way of scoring studies. So you have to score it manually as you score type 1 or level 1 sleep studies. So the advantages of type 3 or level 3 monitor, that it's easy to set. Patient can do it at home. This is what we encourage during COVID-19. I'll discuss that. It has lower cost. It's portable, easy, reduced number of signals, so it's easier to score, easier to do. But it has disadvantages. We discussed some of them. Less signals means you have less data, less information, as we discussed. It may affect, you can score arousal, you can score total sleep time, you can score REM-related sleep apnea. Again, you have to check with the insurance company for reimbursement. I know that in Saudi Arabia now, insurance companies, they start to reimburse for that. Probably in other countries who are attending with us now, or attendees from other countries, probably also they have reimbursement. You have to check for that. Signal loss at home, there is no way to correct because there is no technician. However, the rate of signal loss in portable level 3 is not that high. It's low. It's probably less than 5% if you educate the patient how to do it. Still needs manual scoring. As we discussed, we cannot score arousal, so we have less scoring of hypopneas. Apnea-hypopnea index will be less, as we cannot score arousal. So if any hypopnea does not meet the desaturation criteria, but there is arousal, that will not be scored. That's why the American Academy of Sleep Medicine, they recommended something instead of apnea-hypopnea index called respiratory event index. This term is used to represent the frequency of apneas and hypopneas derived from home sleep apnea testing. So instead of calling it apnea-hypopnea index, which we use for the standard level 1 sleep study, they call it respiratory event index. So if you score and you write a professional report, use this term, REI instead of AHI, because this is recommended by the American Academy of Sleep Medicine 2017. Some of them, they don't have position sensor, so you cannot tell if it is supine or lateral, if it is supine position related OSA or not. We discussed also them. And another limitation, most of the portable or home sleep apnea testing, you cannot connect with it positive airway pressure device. So you cannot have the titration and the monitoring of the respiratory pattern by a good signal at the same time. There are new devices now by some companies that may have that feature together, but in general, most companies, they don't have that, which is a limitation. So when we do the titration unattended, we depend on the data stored in the CPAP or BiPAP device. I will discuss that. So the American Academy recommendations for home sleep apnea testing, we have to abide by that even during this COVID-19. They said that clinical tools, questionnaires, and prediction algorithms should be used to triage patients for indication and contraindication for home sleep apnea testing. And we'll talk about the indication. So home sleep apnea testing is not good for every patient with sleep disorder. Though in these days of COVID-19, some people, they use some waivers, which is okay. Home sleep apnea testing with a technically adequate device should be used for diagnosis of OSA in an uncomplicated adult patient presenting with signs and symptoms that indicate high increased risk of moderate to severe OSA, meaning that you have to assess the patient clinically. If you think that the patient has high likelihood of moderate to severe OSA with no associated problems like hypoventilation, central apneas, heart failure, neurological problems, COPD, or other things that may confuse the signal, then you go with home sleep apnea testing. For other patients who may have comorbid respiratory problems, home sleep apnea testing may not be good and it's not approved. Some people, they use it in COVID-19, that's fine, but it's not recommended by the American Academy because the evidence is not supporting that yet. If a single home sleep apnea test is negative or inconclusive, the American Academy of Sleep Medicine recommend that go to the lab sleep study because published data show that repeating another home sleep apnea testing for the same patient is unlikely to be successful. So if one study fails, go to the lab studies. So the physician should assess the patient. These days, you can do that virtually. We'll talk about that. Should assess and if the patient is good for this type of study or not. Should be a physician who is trained in sleep medicine, not someone who has no training or not a sleep technologist who decide that this patient should go for home sleep apnea testing or not. Home sleep apnea testing for diagnosing OSA should be done only in medically uncomplicated adult patients, as we discussed, with a high pretest probability of moderate to severe OSA. So patients should have absence of significant cardiopulmonary disease, neuromuscular conditions, history of stroke or chronic opioid use, because these patients, they may have higher risk of central apneas, patients with central apnea disorders, parasomnias, narcolepsy, severe insomnia. These are not for home sleep apnea testing. Also, home sleep apnea testing should not be used as a screening tool. It's not a screening tool. This is by the American Academy. You can't say, I'll screen you. You do home sleep apnea testing if you feel clinically that the patient has high likelihood of obstructive sleep apnea. The American Academy of Sleep Medicine does not recommend the use of home sleep apnea test for diagnosis of OSA in patients less than 18 years. This is the current recommendation. I'm not saying don't use it. Some people are using it with good results. That's fine, but I'm just telling you the general recommendations now. Still, it's not approved because younger adults, they may have, children, they may have a lot of like central apnea, so they may not be detected. But there are some anecdotes of successful use of that. So what are the conditions for successful use of home sleep apnea testing? Proper patient selection, appropriate portable recording application, interpretation by a qualified person, accessibility to lab BSG if needed, if the study failed, systematic follow-up of the patient. And you have to remember that this device is good to rule in, but not rule out. If the clinical suspicion of OSA is high and the portable home sleep apnea testing is negative, then the patient should go for a lab global sleep study. Now I'll move to talk briefly about virtual clinics. The aim of this home sleep apnea testing during COVID-19 is to minimize the interaction or the physical contact between the medical staff in the sleep center and the patient as much as we can. So virtual clinics should be used. This our paper now, which is available, it's published now, it's available, you can get it, I'll put it for you from ResearchGate or academia. In the setting of a pandemic, home CPAP testing can really provide some mitigations. Online assessment by a physician to virtual clinic, which we are doing now, and many clinics are doing that. Patient can take the test at home. There is no physical contact between the patient and the staff. Equipment can be delivered through courier. I don't prefer that a technician or something will go to the patient's house, because if they develop an outbreak of COVID-19 in that house, they will blame you for that. So I prefer that you deliver it, either drop it to them at the seal, as we'll discuss here. Instruction to use and safe handling can be through telemedicine or a link that they can have a link for that. Disposable equipments are its components are preferred. Centers do not need elaborate preparation. Just you can talk to the patient, give them a link how to use it. The advantage of home CPAP testing during COVID-19, screening both pre as well as point of contact is not needed, because to minimize contact with the patient is not exposed to the community or healthcare environment. If there is lockdown, alhamdulillah now there is no more lockdown, but if there is lockdown, also this can be done still when there is lockdown. Guidelines, what's recommended is use single-use, fully disposable devices if possible, like for the cannulas, sometimes for the pulse oximeter also can be one-time use. When you go to the BAP titration, also the tubing. The choice of home sleep apnea testing model to ensure home delivery. The patient should be provided instruction guidance to ensure proper setup and safe handling. If reusable devices are used, the units must be cleaned and sanitized according to the infection control guidelines and manufacturer instruction, which will be discussed in coming lectures. It would be best to remove the reusable devices from surface for at least 72 hours. These are recommendations. By that time, the virus will be dead, in addition to disinfection before its next use. Units, I will recommend that should be delivered in a sealed stamp package that has been cleaned and sterilized, given to the patient, so no one will blame you that you cause infection to him or to her. And either you drop it to them at their house to take it, or through courier. Individual responsible for handling and cleaning reusable home sleep apnea testing devices after use must wear appropriate PPE. And this will be also discussed in details. I'm close to finish. Probably I want some fast, but I want to leave some questions at the end for questions. Now, when you do the diagnosis of OSA, then what? Are you going to bring the patient to the hospital for titration? No. Then we go to the second step, which is the unattended CPAP titration at home. And there is good evidence now that the home titration, especially when it is done by specialists, sleep medicine specialists, it is as good as in-lab titration, and probably it's also cost effective. So this will be discussed in more details in the fifth lecture today about monitoring, or fourth lecture probably. You have to remember just that CPAP auto titration should not be used in patients with cardiopulmonary disorders. It's not recommended. Though now we have intelligent devices, if you have a patient with the hypoventilation, cannot bring, I'm not saying don't use it, but in general it is not recommended. It's better to do it in the hospital. But if the hospital is not feasible, probably you can do it for them there, because now we have smart algorithms and new devices that probably can solve some of the problems and look into the waves to make sure that you're not missing any like giant stroke or hypoventilation. Patients who do not snore also, maybe auto titration is not good for them, because one of the algorithms in the CPAP devices is to detect snoring. So this is one of the things that you have to keep in mind. Also, patients with central apneas, again, these patients are difficult, and home titration may not be the optimal solution or the ideal one for them. And when you do the home titration, you have to apply all positive airway pressure therapy precautions, which will be the next lecture. So I'm not going to discuss it because it will be discussed in the next lecture. So the key points here, home sleep apnea testing is a good alternative in patients with a high pretest probability of moderate to severe OSA, particularly during COVID-19 now. This is the way probably to go now until we see how things will go. Home sleep apnea testing should not be routinely ordered in those with coexisting sleep disorders, morbid obesity, severe cardiopulmonary disorders. This is in general. Interpretation of the studies must be done by a trained technologist or qualified sleep specialist. Cannot rely on the machine scoring. A negative portable test should prompt an LLAB DSG, because we said that this technique is good to rule in, but not to rule out obstructive sleep apnea. All patients undergoing portable monitoring should receive a follow-up visit by a qualified physician. These are the two papers. If you want to take a screenshot of them, you can get them from ResearchGate or academia. This paper is already published. The management of aerosol during non-invasive ventilation for patients with sleep disorder breathing, important messages during the COVID-19 pandemic. And this paper has been accepted, and it has a DOI now. It's available in academia and ResearchGate, and hopefully will be published like in 2 weeks. But you can get it now. It's available online. Reopening sleep medicine services in the conundrum of an ongoing COVID-19 pandemic. So I'll stop here, and until the next speaker will be Dr. Saleh, I can see if there are some questions. You can prepare your slide, Dr. Saleh, while I scan through the questions here.
Okay.
They say if you can send the webinar recording, Mr. Awad, we can see later where will we post. Are we going to have it on YouTube or in the center's website or where? So probably we should advise the attendees by the end of this talk, where will the recording be if they want to go to it. Okay, Saleh, maybe you can start, and in the panel discussion, we'll get all the questions.
Sure. Okay. So, Assalamu alaikum wa rahmatullah. Hello, everybody. I am Dr. Saleh Al-Aisi, pulmonary sleep medicine consultant, University Sleep Disorder Center. My talk about the management of aerosols during non-invasive ventilation for patients with the sleep disordered breathing, important messages during the COVID-19 pandemic. So my outline will, on completion of this lecture, the participant will be able to understand what are aerosols, understand the risk involved in handling aerosol generating procedure, practice guideline to handle aerosol generating procedures, apply method modification to minimize aerosolization, and apply best practice guidelines. So what are aerosols? So aerosols are particles suspended in the air that can contain a variety of pathogens, including viruses, and their classification is debatable. Arbitrarily, aerosols are categorized as a small droplets, which are usually called aerosols exclusively, and large droplet with the small droplet having the potential to dry and form droplet nuclei that travel long distance, while large droplets do not evaporate before settling on surface. And this aerosol classification has a clinical relevance in relation to the dispersal properties and pattern. But it's also important to classify aerosols according to where they deposit in the respiratory tract.
Dr. Saleh, yes. The voice for a few 2 seconds was not clear.
Okay.
Just
most often 5 micron in diameter is taken as a cutoff for a small droplet, while another possible cutoff between aerosol types is 20 microns. since the aerosol less than or equal to 20 micron diameter can desiccate to form a droplet nuclei, and aerosol more than 20 microns do not deposit substantially in the lower respiratory tract. So in a study by the Van Dormel et al. Experimentally generated aerosol particle with SARS-CoV-2, as shown in red figure, were found to have a virus that was viable in cell culture throughout the 3 hours of the aerosol testing. And they found that the stability of SARS-CoV-2, as showing in the figure as a red label, was similar to that of SARS-CoV-1 under experimental circumstances test. And this indicates that the difference in the epidemiological characteristics of this virus probably arise from other factors, including high viral load. High viral load in the upper respiratory tract and the potential for potentially for the person to infect with SARS-CoV-2 to shed and transmit the virus while asymptomatic. And the results indicate that the aerosol and fomi transmission of SARS-CoV-2 is plausible. Since the virus can remain viable and infectious in aerosols for hours and on surfaces up to days, depend on the inoculum shed. And this is very important to consider. Risk of transmission of COVID-19 to a healthcare worker. So the aerosol generation can occur during the aerosol generation can natural process like coughing, sneezing, or expectorating. However, current evidence suggests that while it is possible that coronavirus can survive in aerosol from within the fluid particle under certain conditions, this is not the primary source for infection in healthcare worker. However, the natural processes are presumed to be potential transmission mechanism in healthcare worker beside therapeutic or diagnostic aerosol generating procedure. The procedures that are believed to have a potential to generate aerosols and droplet as a source of respiratory pathogen, including positive pressure ventilation, bronchoscopy, and other. Respiratory procedures are known to stimulate coughing and aerosol generation and transmission of infection. However, that is not quantified. Thus, these procedures are to be handled meticulously. You hear me?
Yeah, now we hear you. It went off for some time, it came back now.
Okay. Aerosol generation procedure take place at home and in the hospital. So aerosol generation procedure that take place at home, including non-invasive ventilation, home oxygen therapy, and home apnea test. So patients with sleep disordered breathing need to use their positive airway pressure BAP device during the pandemic that may last for months to come. Besides, CPAP use can have a bearing on overall mortality and morbidity in those patients if infected with SARS-CoV-2. So practice guideline to handle aerosol generation procedures based on the literature and personal experience, the following is suggested. Universal isolation for NIV at home is impractical. Hence, it has to be individualized. Temporary cessation is a plausible option taking into the consideration the risk of withholding NIV in patients with hypercapnia. However, this needs to be discussed with the treating physician in patients with whom the NIV therapy cannot be temporarily stopped, such as a patient with severe obesity hypoventilation. Complete home isolation is preferred to minimize the risk of aerosol spread among the household. Other plausible options are modification in the device and interface of NIV to reduce the risk of aerosol dispersion will be discussed later. Following advisories are highly recommended: changing the machine filter routinely and cleaning surface and cleaning mask tube with hand hot soap water and washing up liquid and washing hand regularly. So for home oxygen therapy, isolation is a must to prevent viral dispersion if there is a suspicion or a confirmation of COVID-19 infection. So the setup, if you look at the setup for CPAP or NIV, bi-level ventilators for patients with the sleep disordered breathing is built to work with single tube and relatively constant intentional leak. If you see my arrow on ventilator and delivering the pressure to the interface, if you see the white opening, this is what we call it the intentional leak. You can do a closed single tube circuit with exhalation valve. So this is the ventilator delivering through the interface that is non-vented mask. So there is no opening for intentional leak. It will be in the circuit. You can do a closed dual limb circuit with one with inspiratory limb and one expiratory limb. And if non-vented mask is used, open single limb circuit, an additional exhalation valve in the circuit must be added to allow CO2 removal. Clinician and respiratory therapists must be aware of this important difference between ventilator, because the use of non-vented mask in open single tube system without exhalation port in the system can be disastrous. So if you look at the air leaks can be intentional leaks and like a hole in the holes in the mask. And this is the holes in the mask as you see. Or in the circuit valve, like the valve, you see. Or non-intentional leak that we don't want, like dissipating from around the face or through the mouth if you use nasal mask. So the intervention to reduce the leak, how can you make a modification in the non-invasive ventilation so that you can prevent the spread of the COVID-19? The circuit consists of non-vented mask, as you see here. So there is no opening for intentional leak, followed by bacterial viral filter. This will collect the secretion of the patient and will not allow the transmission of the COVID-19 to the healthcare workers. Then you can add the oxygen entrainer after the filter and exhalation port, and then you can add safety valve. This is in case there is a power failure, so that it will take action and the patient can breathe through the safety valve, and leak valve to remove the CO2. So if you mouth leak, if a nose mask is used for infection control, one must avoid nasal mask. Because if you see here, when the patient is on a nasal mask, there is the air can get out through his mouth. So that we must avoid the nasal mask during non-invasive ventilation. So for CPAP, the three recommended interface are, the most important is a full face non-vented mask. As you see, there is no mask. There is no intentional leak. It must be after the filter. Leak around the mask face contact. Well-fitted oronasal mask over the whole face or helmet should produce the least droplet dissemination. Vented mask could worsen contamination of the environment. Ensure that the ventilator mode employed support the use of non-vented mask and exhalation port. The sequence of action will be NIV mask on, ventilator off, NIV mask off. Leak through the intentional leak, as I described, a viral bacterial filter should be placed in the circuit between the mask and the oxygen and exhalation port. So this will prevent the transmission of COVID-19. An external humidifier must not be used because risk of infection and transmission of COVID-19. Blocked filter can be mistaken for clinical deterioration, and this issue is remedied by changing the filter. So safety valve, this is integrated in some mask, allowing the patient to breathe in case there is a power failure. Tube connected to whisper swivel type valve, also called leak valve, by some manufacturer will work as intentional leak port. So this is a real image of how can you create a modified non-invasive ventilation by using non-vented mask connected to the viral bacterial filter, then connected to a safety valve, then connected to whisper swivel valve.
Dr. Saleh, some say that the slides are small. No, did you use the slideshow?
Yes.
Okay, that's fine. Continue.
You see it now?
I can see it clearly, but I have comments saying that the slides are small and they have some difficulty seeing it, but I can see it myself. Okay, continue.
Okay. So in case of emergency and you don't have like non-vented mask or there is lack of resource, especially during COVID-19 infection. So what you can do to modify your non-invasive ventilation, start by take a regular mask and block the intentional leak port, and then connect it to bi-level with Y connector, which is simply bringing two tubes that allow to make T or Y connector. And this connector will be, you have to, because you're creating now an intentional leak, you have to create something called a restrictor, which is not allow the pressure of ventilation to dissipate through the outflow intentional leak new, so that you will make a restrictor. It will allow you, just the restriction by making like a pillbox, and you make a puncture inside the pillbox with 18 gauge needle. So this will restrict the flow through the intentional port created by you, then connected to the filter. So this can be done in situation like emergency, you don't have equipment, so you can create and invent a modifiable non-invasive. Okay, so summary, aerosol management during NIV use can be achieved through temporarily suspending the use of NIV, following standard infectious disease protocol and modification of NIV interface and tubing, and to limit the aerosol dispersion during NIV use. Thank you.
Okay, thank you, Dr. Saleh. We'll take now some of the questions, and we are doing very well actually with time, very well with time. So we'll take now the panel discussion. All the panelists probably will try to ask now the question that we had. I encourage the attendees to ask, because in this kind of webinar workshop, we lack the interaction that we usually have with the attendees when we do our usual workshops. So some points may not be cleared when they are illustrated for the first time by the speaker. So please, if you have any question, just write it and we'll try to address it. Dr. Rauf, there was a question before that we couldn't answer. They say, what about recovered cases of COVID-19? How would you handle that?
Yes, there's a recommendation.
But raise your voice, Rauf.
For the patients who have recovered from the COVID-19, it is a must to have a swab negative PCR test.
Okay. So before they go like for testing and or to use the positive airway pressure devices at home, like in a common place, in a common room, they have to have PCR negative.
PCR negative, as well as they should be asymptomatic PCR negative.
Okay, so they should follow the recommendations by the CDC and the Ministry of Health, and so there are other Ministry of Health in other countries for how to define a patient recovered patient. Okay, okay, very good. Mr. Mashni, let me ask you here. One of the attendees asked, what about like taking the risk of damaged home sleep apnea testing devices? Do you have any experience with that?
Actually, we are not encountering any damage usually, because we have a well-established, guideline and agreement with the patient, and it's rarely it's happened, because usually patients they are aware about this. But in case of it's happened, actually there is no written or setting penalty for that one. Usually the patient is encountering only on the device, the movable or the disposable part of the machines. We have accessories that we can take it from the company, but the most important, if we say damage, that the main machine would be damaged, even through waters or through any kind of damage. This is the things that we will report it as an incident report, then we will try to purchase another one. But this is rarely happening.
Is it common to have damage, like in how many studies you have one damaged device?
Actually, I didn't count it. For all of those years that we starting to use especially the home, we don't have it. And it's very rarely it's happening. I don't know if there's another center where they have the same.
This is actually most of people who use home sleep apnea testing, they say it is unusual to have damaged or lost devices. This is the experience of people who use that. Yeah, probably like in the private sectors, maybe I don't know if they can have insurance for the device. I don't know if they can do that. Maybe this is one solution, that they can insure the device in case of damage, then the insurance company will replace that or fix it.
Yes, Prof, there is some like in our hospital. Also, I am sure that in other hospitals there is a committee that it's if you report those damaged devices, they will just investigate on it and they will put it for replacement. And as you said, also, Prof, that nobody's or rarely if you recall any damaging machine. So that's
okay. There is a question about, probably I'll take this question about auto titration after home sleep apnea testing. Of course, we do home sleep apnea testing to do auto titration after that, because if we will do home sleep apnea testing to diagnose, then bring them to the hospital to do the titration, then there is no point. We can just bring them for the first time and do a split night study. So the aim is to do everything at home to reduce the flow in the hospital, reduce the in-person contact. So when you do home sleep apnea testing, the next step, if you diagnose OSA, is to go for auto titration. Okay. There is a question maybe Mariam or Smith can handle. They say in OSA patient, this Haytham is asking actually, our friend, he say he has a patient with obstructive sleep apnea, but he's not comfortable with his device now. So is it enough to adjust the device based on the CPAP data, or does the patient need to undergo another sleep study? Okay. Mariam or Smitha, who's around? Okay, Smitha. Smitha, are you with us? Okay.
Hello, Assalamu alaikum.
Yes, ma'am. Yes, Mariam.
Yes, Assalamu alaikum. As what we are doing, if we found the patient is uncomfortable in using the machine, so we have to check first. We have to book the patient for CPAP clinic, ask what are the problems why the patient is uncomfortable. And if really the patient needs to do the sleep study, and that's the time we will book the patient. We will give him a questionnaire for the patient. So then after that, the doctor will assess, and then for that, the doctor will check if the patient really need to do a repeat sleep study. But first, we have to check what are the problems that the patient is encountering before we will do a sleep study for that patient.
What are the common problems that you see in the patient with the use CPAP? When you download the CPAP data, what are the common problems that you face that makes the patient uncomfortable, like leak or what?
Hello?
Yes. Did you hear my question?
Yes, Prof. The common problems usually with the leak. That's why they are uncomfortable, because sometimes they don't know how to fix the mask very well. So from the downloaded data, we can see that the patient is having a lot of leak. Then from that, the patient is feeling uncomfortable.
Yeah, so probably one of the commonest problems of being uncomfortable is leak, whether it's leak like around the mask, or if you use nasal mask. Some patients, while in the center, they may tolerate the nasal mask well, but when they go home, they will start to have leak in the mouth, through the mouth. And that will wake them up, either after they have dryness or immediately once they have start to have the leak, or their mouth will be swollen with air, they wake up immediately. So this is one of the commonest problems. Probably in the coming lecture that we will discuss the devices and telemonitoring, probably we'll have some about that. Okay, Dr. Saleh, what's the non-vented mask?
Non-vented mask is a mask without intentional leak, so that it needs to create intentional leak through valve, like a whisper swivel valve, so that the CO2 will go through the whisper swivel valve. So this is the non-vented mask, different from vented mask in the presence of intentional leak. Intentional leak, usually in the vented mask, usually it is in the, as I show you in the picture, it found on the mask itself. While non-vented mask, it must be created in the circuit, the valve, for intentional leak.
Okay. Why do you have to use bacterial and viral filter?
This is will prevent the spread, because the patient, when you give him pressure and aerosolization, he could secrete what we call it COVID-19 infection, so that this is where the filter will catch the virus and will not allow it to transmit to healthcare worker.
Okay. Dr. Rauf, there is a question here. Is there any place for using a HEPA filter in the sleep lab, full PPE for technician to be able to perform full attended sleep studies? Is the question clear?
No, I didn't understand the question, to be honest.
Is there any place for using HEPA filter in the sleep lab and full PPE for technicians to be able to perform full attended sleep studies? And please raise your voice.
Yes, we talked during the lecture also. If we are doing a sleep study in a patient, the usual recommendation is if a patient is COVID positive or he is symptomatic, we don't have to go for any sleep study or any titration study. But in case of emergency, while we don't have any other way, we can take these patients in isolation rooms, which is a negative pressure room and full PPE. Like we take patients like for BiPAP, a COVID patient who comes to hospital, they are many of them are on BiPAPs or high oxygens, or they are on ventilators also, which definitely will produce aerosolization. So for such patients, what is recommended is a negative pressure room and a full PPE.
Okay, so just if I could,
highly emergency situations.
Okay.
Otherwise,
if I may comment on this, the recommendation now is to use full PPE for sleep technologists when they interact with patients for sleep study, whether they will use CPAP or not, because they work in close proximity to the patients. So they should have full PPE. But if you have to titrate CPAP for a patient who is probably COVID-19, you have to do it in an emergency situation or still waiting for the results, not sure, then it is recommended to go to a negative pressure room. But negative pressure room is not for all titration, not for all sleep studies, only if patient is having COVID-19 or likely to have or waiting for the results. Otherwise, when you do in-lab sleep studies, you have to do full PPE protection. There is another question here, and they say, patient in the Ministry of Health, if non-healthcare workers, they do not apply a second swab to be cleared. What do you suggest in this situation, Dr. Raouf?
This is basically the recommendation of CDC and AASM. But whenever we have to modify the recommendation according to the local Ministry of Health these recommendations. Whatever
but still, I mean, the safety. See, I mean, the Ministry of Health, they will send patients home. They don't do a second swab. They don't send them home because they will be home. But if we are talking about patients who probably will need CPAP, so there's aerosol probably will be there. They have to have a swab. You cannot take a patient because they say he's recovered without a swab. This is the recommendations. Because when you deal with aerosol is one of the areas where there is high risk of infection. And it is recommended to have a swab for patients. They should not be treated like patient recovered and they go home. They are different. They are admitted now under boosted pressure. Probably there will be some aerosol, even if you use all the precautions. So this patient must have swab.
Yes, as we talked, we should have COVID testing. Not only it's very important to have a COVID testing in a reasonable time frame. Like a patient who is COVID positive previously, now he comes again, we have to have one more COVID test so that in a reasonable time frame, so that we can be sure that he is negative.
Okay. Another question about home sleep apnea testing, is it good now to do in Saudi Arabia? I think if you have it feasible and you have the setup, yes, you can do it. What about the question, what about technologists visiting the patient at home to do the setup? That's fine, but in general, what's my concern always, these are easy devices, the patient can do it through a virtual clinic, teach them how to do it, or the video link. You have to keep in mind that if they have an outbreak of COVID-19 in that house, they will blame you immediately for it. They will blame you. They will say that you brought the infection to us, even if they spend the whole time in the coffee shop. But of course, you can go to do it to help the patient if we want to go to the lecture. We have still some time, but I'll take just one question, then probably we'll go. They say, how can we know that the mask is fit for the patient? This probably beyond the scope of this talk, but we can check for the leak. What is the acceptable mask leak? This probably we'll discuss it probably in the other lecture. Is there any chance to use portable home sleep lab or sleep testing during the pandemic? Yes, this actually is a good chance. Even in your hospital, it's a good time now to push for home sleep apnea testing. Probably they will approve it for you. If comfort room is outside the patient room, what precautions or instruction should a sleep technologist instruct or provide? Dr. Rauf, you want to answer this?
Yes. As we talked, like it depends about the status of the patient. If we are suspecting that the patient is COVID positive or he is COVID suspect, then it is good to have a comfort room inside the negative pressure room. But for the other patients, they can use the comfort room even if it is outside the patient room.
Okay. Okay. So there is a question here about like to use nasal or full face mask during titration. In general, for sleep apnea, we prefer to start with a nasal mask. And we have a paper that Dr. Saleh showed in his slide, but it was small font, that we talk about different masks for sleep apnea. But in this current situation now, of COVID-19, face mask is, when you do it in the lab, face mask is better, and non-vented face mask is the first choice to avoid aerosol. But when you talk about general situation, nasal mask in general is better for patients with sleep apnea. With it, you require lower pressure to open the airway compared to the full face mask. There is a paper we have recently published about the choice of interface for patients with obstructive sleep apnea. You can look it up, it's available online, and then we discuss all of this. Okay, so I think now we'll move to the program, and we'll go to the technicality part in more depth. We'll have 4 talks, and we'll start with the or 3 talks actually. Dr. Faisal Abdel Nabi will talk about positive airway pressure. Dr. Faisal.
Good, Professor Bahman. I'm just sharing my screen, and let me know when you see it.
Yeah, we can see it now. Yes.
Excellent.
Please keep all mute so there will be no echo in the sound.
Assalamu alaikum. Good evening, everyone, and thank you for joining this this webinar. The presentation that I'm going to talk about will be about applying positive airway pressure titration methods in post-COVID-19 and what are the recommendations. So I'm going to talk about in this agenda, I'm going to talk about the learning objectives, the scope of the problem, and then I would run through 2 aspects of mitigation strategies. I'm going to talk about in-lab positive airway pressure titration and home application of PAP therapy. And in both sections, I'm going to go a little bit deeper in some technical aspects of the equipment setup, and also talking about remote monitoring and the use of telemedicine. The objectives of the lectures at the end of the session, we hope that you will be able to understand the different options on how to titrate positive airway pressure therapy for patients who are diagnosed with sleep apnea. And also, we hope that you will be able to learn some practical aspects related to virtual sleep unit management, and I'm going to use some concrete examples. So without further delay, what is the scope of the problem? So the COVID-19 pandemic has fundamentally changed the operation of healthcare systems around the globe, and resources have been shifted from elective care to acute management of ill patients. And according to the current recommendation, the sleep medicine services are advised to reduce the in-house services and more to provide medical care by using remote options like telemedicine, like phone calls, etc. So, and we have seen also that in majority of the countries, initiation of positive airway pressure therapy has been reduced. So this is a paper that was published by the ESADA group. So the ESADA group is a network of sleep labs in Europe. And they have been looking to the numbers prior to the COVID-19 pandemic and during the COVID-19 pandemic. And what is interesting to see here is that both CPAP treatment procedures as well as follow-up of PAP treatment, both of them have been dramatically reduced from the period of post-COVID prior to COVID-19 and during the period of COVID-19. As you can see the numbers, so there is a drop, for instance, in-lab titration from 90% before to 70.5% after, as well as follow-up, in-lab follow-up has been dropping from 82% to in-lab follow-up to 7.5% after or during the COVID-19. So this is just to give you an idea on the scope of the problem here. So we know that obstructive sleep apnea has, in patients who have cardiovascular complication, can be a risk factor for COVID-19 disease. And that's why it's very important to find mitigation strategies in order to continue the practice of sleep medicine, even during these episodes of pandemic period. So what are the mitigation strategies that I'm gonna to run with you here? The main point is really to reduce and to minimize the direct contact with the patient room and equipment. And here we can see that the ASM recommendations are going in that sense. So ASM has been providing resources. You can see the resources here in that link, where they recommend the use of remote contact approach and telemedicine solution. So let's start with the in-lab titration of positive airway pressure therapy. I want to be here a little bit more practical, and I want to talk about the technicalities of the remote titration setup. When you have patient in the lab, how can you do a titration? So here in this example, so the first thing that you need to start with is to use the appropriate setup to connect your titration device. You need a titration device in the unit, and you need a polysomnography system in the unit as well. So you need to find the right setup to connect both the titration unit, the one that you can see here in this example on the left side, to your polysomnography system. So, and in this case, from the technical point of view, there are what you need a kind of what we call a connecting box. In this example, we're using here the OmniLab Connect, which is the white box that you see here. So this is the box that you use to connect your titration device to your polysomnography or control room. And there are two cases from the technical point of view. Case one is when the box is placed in the patient room, and case two is when the box is placed in the control room. So case one, you can see here the example. So on the left side, you have the patient room, and on the right side, you have the control room, the monitoring room. And you can see that the box here is installed in the patient room. And here you can see that you have the cables that are going to your polysomnography auxiliary inputs. The other setup, which is case two, is when you have your connecting box placed in the control room, and then your polysomnography auxiliary inputs are going to the are placed in the control room, and then they're going to your PSG system. So these are different setups. Of course, we are not going to detail this. This needs to be worked with the manufacturer that you have in your unit and with your biomedical team in order to make sure that this setup is working properly. So next step would be to choose the appropriate cables and connectors. You will see that there are many cables, many connector types, so you need to choose the one that are applicable to your setup. And then you need to connect your titration device, as you can see here on the picture, to your connecting box. So you need to find the right cables that are going from the device that you use for titration to the box that is going to go or to connect the signals to your PSG system. And of course, the third step would be to connect this box, the OmniLab Connect here in this example, to the control room where the computer is positioned. So here is in this slide, you can see that in the next step, you need to determine what type of PSG cables you will require. For instance, there are two types. There is the mono connector and the stereo connector, and you can differentiate between both of them. In the mono connector, so you have only one ring. Maybe you can see it, it's small, but it's one black ring here. And the stereo connector is easily identified by two rings, one here and one here, for instance. And then you need to determine the connector type that is on your PSG system. So depending on your PSG system, so you will easily recognize what type of connecting you will need. And then you connect your box, which is the OmniLab Connect here, to physically to your PSG auxiliary system. So here we have 4 channels. You can see that this is the first channel, this is the second channel, etc. So you need to connect those channels from the box to the PSG system. So just pay attention, as I mentioned before, if you have a polysonography system with who require mono connector, so these are some examples of mono connectors, so with different diameters like this one or the RG12. And if in some cases you have devices or polysonography systems that require stereo connector, in that case you need to use the appropriate connector. What would be the next step? The next step is the use of the appropriate software. So in this example, this is OmniLab Direct, which is the software that will provide you the ability to monitor remotely your titration device from the control room without going into the patient room. So easy control of the titration procedure from your control room, reduce the contact with the patient room, and avoid having interactions which might disturb the patient during his sleep. So you can see here in this screenshot of the software that you can choose the mode, the titration mode that is needed for your patient. So you are not stick only to CPAP mode, but you can use the different modes that really apply for your patient. You can also program the parameters that you need or you want to monitor. And here you can see that you will be able to remotely change the settings and the parameters of your device. Very important as well is the ability that you need in the systems that you are going to use, your ability to make additional adjustments. So you need, for instance, to be able to configure the pressures, the unit you want, the unit where you want to see your to display your parameters, what type of leaks, whether you want to see the total leaks or other types of leaks, what type of tubing, etc. So all these can be very important and interesting aspects that you can configure through the system. Last but not least, which is the calibration. It's very important to be able to calibrate properly the signals that you are going to display on your polysomnograph. So here in this example, on the left side, you see what you have on your screen. So you have, if you choose, for instance, if you are in CPAP titration, then you have different signals that can be displayed on your screen, and then you need to titrate them, or to calibrate them. So for instance, here you have the pressure channel. Pressure channel goes from 0 centimeter of water up to 20 or 30 or whatever. So the calibration procedure, as you can see here, you will calibrate the port, the adequate port which is between 0 and 1 volt. So you can see here, this is the 0 volt, which is equivalent to 0 centimeter of water. And this is 1 volt, which is equivalent to 30 centimeter of water. Then you have the flow. So the flow channel, as you can see here. So flow, you have inspiration and expiration. So it's minus and plus. So basically when you do the calibration, so you need to use not the 0, 1, but you need to use -1, +1 volt port. And you can see here that this is the 0 line. So when the patient is not breathing, and this is -200 and +200, which is liter per minute. So equivalent to +1 volt, -1 volt. So this is very important step that you need to do also as part of the setup. And finally, you will be able to do your titration remotely and to choose the mode that is more applicable to your patient. So whether you have a obstructive sleep apnea patient, whether you have patient with more complex disease like Cheyne-Stokes breathing, or patient who need BiPAP titration. So all of this can be remotely adjusted and in order to do a proper titration. And finally, you will get to display the settings on your polysomnography system. So for instance, here, this is a CPAP titration procedure, and where you can remotely see from your control unit, you can see your CPAP parameters. So now what about patient who need titration at home? So in the case where you need to do titration at home, what do we have in terms of possibilities? So there has been a lot of development in telemonitoring, which allow patients to be closely monitored and also allow for remote adjustment of the ventilator settings. You can see here in this, from this paper, that from the early invention of the CPAP therapy to nowadays, so physicians and clinicians, they have, so the more we progress in years, so you see that the level of information that are derived from the PAP therapy device is becoming very important. And also a very important step has been achieved from 2010 and onward, is the introduction of the remote control of PAP therapy devices using the telemedicine approach and proprietary softwares. So this is bringing us to the topic of virtual titration. And Professor Bahamam has been talking about the virtual unit. So what setup you will need for the virtual titration? There has been a recommendation from the ATS published recently saying that if PAP titrations cannot be performed, patients can be initiated on auto CPAP units based on home sleep testing or PSG results, and they should be followed closely with remote monitoring of PAP data. So the setup is pretty clear. So you will need an auto titrating device auto titrating device, which is auto CPAP, or a fixed CPAP with titration features, so you can be able to titrate your patient remotely. You need connectivity through GSM or Wi-Fi modems, You need to have a telemonitoring virtual platform for the patient's data management. And you need also to have a secured access. So whether you are prescribing physician, whether you are the sleep lab care team, or whether you have home care providers, so you need to have a multi-level secured access. So physician will have different access type than home care provider or than a sleep technician, for instance. And last but not least is the possibility to, in this setup, to remotely control the device settings and the modes. So this is one example where you can see a CPAP device is placed in the patient home. So the CPAP device will include inside a modem, whether it's cellular modem or Wi-Fi modem. We're showing here example from one existing setup, and the data will be transmitted automatically from using the modem from the device through the cloud to where the patient or where the physician can get access to the data. So data on daily basis, compliance data will be sent, as well as waveform reports. And you will see that waveform is an extremely important information that is needed for the physician and sleep technician in order to see how the patient is performing. So let me give you some examples of, here we are showing an example of Care Orchestrator telemedicine platform. So this is the platform that is going to be used by the sleep lab team in order to review the patient data. So the first thing, which is very important, is the access. It's a secured access. So you need really to make sure that you have secured access to your patient data. Then once you are in there, so you have very important aspects of what are the priorities. I have several patients. So what are my priorities? Should I pay attention to all patients, or should I pay attention more to those patients where I have some alarms? Here, for instance, I have in this screen, I have some patient with high apnea-hypopnea index. This is a high alarm. I have patient who has been non-compliant for the last 30 days. So these are the type of patient that need and will require more attention. Then when you go into a specific patient, it's very important to be able to, without going into details, but at a glance to see first what are the key parameters that need to capture your attention. So for instance, here you see that some of the parameters like the compliance, like the leaks, the average apnea-hypopnea index, including different types of indices like central apneas, obstructive apneas, as well as the P90. So the P90 here is the optimal pressure that will be provided by the auto CPAP unit to tell you this is most likely the pressure that can be applied to correct all respiratory disorders patterns. So when you go into details, into analysis, you will be also interested to see the compliance. So reading the compliance has an extremely important place when doing this remote monitoring. So for instance, you can see here that during the weekend, so maybe this patient is spending more time in his bed, so he's sleeping more, and during the weekdays, so he's sleeping less and he's sleeping, for instance, here 7 hours, so he wake up earlier, maybe to go to school or to go to work. Another important part, which is the waveforms. So what I forgot to mention here is that having access to the compliance data is good, but it's very important also to have access to the waveform data. And you can see here this blue icon. So this is the waveform data. When you generate the waveform data remotely, you can get a lot of interesting info. For instance, here, if you can pay attention, this is the waveform. This is in blue, the flow, and in red, the pressure. And you know that usually the flow has inspiration and expiration. But interestingly, here in this example, you can see here that we have only inspiratory phases. So where is the expiratory phases? So here, basically, the patient is breathing through the nose, so inhaling through the nose and exhaling through the mouth. So this is what we call mouth breathing. So this is very nice way to detect mouth breathers and maybe to provide instructions to your care team to change the mask, maybe to switch to another type of mask or to do a different type of adjustment. Also, in some cases, you will see that you have patients who will develop some complex patterns. So for instance, this patient is developing what we call a chain-stocks breathing pattern. So you can see here this weaning and waxing waveform, which is clearly reminding us the chain-stocks breathing pattern. So this type of patient, we need really more attention. And maybe if this patient was on auto CPAP, maybe I would see to change the settings here and put my patient maybe on fixed CPAP, because we know that auto CPAP will not be able to treat the chain-stocks breathing pattern. Also, another important aspect which was mentioned in the previous lecture or in the panel discussion was about the leaks. I think it's very important that we recognize where are the leaks. For instance, here you can see that this patient is having a lot of leaks, and leaks means that patient may be not very comfortable with the therapy and may stop the therapy. So it's very important to detect those patients and to provide them with the right mask sealing. So prescription. So remotely, you need to have the ability to change the prescription. For instance, in this case, I have a patient with auto CPAP, but then I decide, to switch him to fixed CPAP mode. So I need to do this remotely and not having the patient to come back to the sleep unit. So and then you can change your settings, you can change your pressure settings, your features, etc. And what you can do is you can save and send remotely the prescription. So in this example, you see that you send the prescription to the modem. So you remotely, virtually, you're going to set a new therapy for your patient. Your patient, for instance, was on auto CPAP and he developed complex sleep apnea. Then you want to put him on fixed CPAP. So you need to be able to do this remotely thanks to the telemedicine approach. Also, very important aspect is reminders. You want to put reminders for your patient remotely. So ask them to change their filter. So those reminders can appear on the patient platform. So patient will know that he has to change his filters. But also you need to put some tasks to your teams. For instance, here you can put some rules for your teams. So talking about rules, there are some important aspects in the rules settings. For instance, respiratory rate or minute ventilation. It's very important to detect patient where you have a change or a significant change or a sudden change in the minute ventilation and the respiratory rate, and to put this as alarm. So put for high priority, for instance, in the respiratory rate. Why I'm saying this? There has been a paper published by the Grenoble team in 2015 where they have been looking to COPD patient, and they were looking to the days prior to exacerbation. And what they found is that prior to exacerbation episodes, there was an increase in the respiratory rate as well as an increase in the percentage of triggered cycles, which were predictive factors of exacerbation. So that's why it's very important to put this type of alarms and rules to detect those patients who might develop some issues in the future. So I want to conclude my talk by just showing this slide on a nice paper that has been comparing the hospital in a randomized control trial. They have been comparing the hospital setting to a virtual sleep unit setting, and they have been in the hospital setting. They have been putting patient on fixed pressure, and in the virtual sleep unit, so they put patient on auto CPAP and they send patient at home, and they followed the patient for 3 weeks. And what, sorry, for 12 weeks, not 3 weeks. And what the study was showing is that in when you compare the virtual sleep unit versus the hospital routine, you see that the total cost, so the cost effectiveness part, the total cost related to OSA, like what you see here, and the total cost in general in a virtual sleep unit is much lower or significantly lower than the routine, the hospital routine setup. You can see here the numbers. You have the reference. So if you want to see, it's an open access. It's very interesting to see really the differences that are showing that basically the cost effectiveness analysis planner here was showing that it was most cost effective in virtual sleep unit setup versus a hospital setup. So the key points in this lecture, and I hope that you get them, is that PAP titration procedures can be done with minimal contact with the patient and his equipment. The titration can be done in the lab using a remote setup or at home using a telemedicine platform. And it's very important to be able to virtually monitor and follow up the compliance data. And thank you for your attention, and sorry for taking a little bit more than the time that was allocated to me.
Thank you, Dr. Faisal, and thank you for the attendees who are still with us. We have 2 more short talks before we answer the remaining questions. We'll have a lecture about disinfection guidelines for sleep diagnostics. You'll see what are the recommendations for cleaning the diagnostic equipment that you use. Then we'll have a short video about the disinfection of equipment. Next talk will be by Engineer Anas Naji. We'll talk about disinfection guidelines. Yes, Engineer Anas, please.
Thank you, Doctor. I'm just opening my presentation. Can you see my screen?
Yes, we can see it. Yes, you may go ahead.
Thank you, Professor. So hello, everyone. My name is Anas Naji, and I'm going to talk today mainly about the disinfection guidelines for sleep diagnostic devices. So mainly I will be talking about the equipment. So this would be the agenda of today's presentation. I'm going to talk about the COVID-19 and sleep diagnostic. I'm going to talk about we'll give you a short introduction about sleep diagnostic or sleep lab in general. Then I will go you through the disinfection guidelines for in-hospital sleep lab, as well the home sleep diagnostic equipment. And by end of my presentation, I will give just a quick or general recommendation and guidelines for performing sleep studies in general. So let's start first with the COVID-19 and sleep diagnostic. Now, as all aware, sleep lab were closed since almost March 2020, which led to limit the support for many sleep apnea patients. However, these days, we can see that everyone is trying to live with the disease. And as sleep labs, we are trying to reopen and re-support those type of patients. Now, in general, we can see that Center of Disease Control and Prevention, CDC, as well, the WHO, World Health Organization, didn't perform or didn't approve any disinfectant list in order to fight COVID-19. But if we look into the Section A of the CDC guidelines, we can understand that most likely COVID-19 virus can be listed in category 1A. And what do we understand, or what does it mean, category 1A? That means that CDC is highly or strongly recommended to implement a well-designed disinfection procedure to avoid spreading the virus. That means we need to look to the disinfection guidelines that has been published by the manufacturer in order to prevent the spreading of the disease. And as of now, most of the leader companies in sleep, they have already published their disinfection and guidelines. So this is just one slide. It's talking about the introduction about the sleep diagnostic. As most of us are actually aware about what is a sleep lab, just would like to refresh it with you quickly. So sleep lab, normally it's designed into two partitions. The first partition, it's we call it the patient room, and the other partition, we call it the workstation or the technician room. Now, patient room will be equipped with the device itself. It will be equipped with the base station, which is the analyzing of the data. And we have the hitbox, which will be collecting the information from the patient. We have as well camera, which will be recording the patient during sleeping to detect his movement. As well, we have a microphone and speakers in order to make the communication between patient and the technician. At the same time, we have the titration system, which can perform the ability to do split night or titration study. So basically what's happening, the collector or the hitbox will be collecting the information and send it to the analyzer or the base station. Then the analyzer will send the information to the nurse station. At the nurse station, we have a PC, which will be equipped with a special software that can translate the information from the base station into like a data that can be read by the technician, like waveform or signals. The technician will be monitoring these data and do the scoring analysis for the patient. And by end of the study, he will generate a report which will be sent to the physician in order to make the prescription or the recommendation for the patient. So that's in general. Why I'm showing this slide, it's mainly to give you an idea what are the equipments that the patient will be in touch during the sleep study. So we can see electrodes, we can see some sensors will be connected. We have the hitbox, the base station, and even the technician who will be in contact with the patient. So all these information should be taken into consideration while we do the sleep study during the COVID-19 era. So first of all, I would like to start with you with the in-hospital sleep lab. As you all are aware, we have two types of sleep study equipments. We have the hospital sleep lab and we have the home sleep apnea testing. So we'll start first with the hospital sleep apnea testing. And even for the hospital sleep apnea testing, we have the main devices, as you have seen, the hitbox, the base station, and even we have a pressure transducer, which is connecting the nasal cannula for the patient. So how to disinfect the device itself, as well the hitbox. Normally, you need to get a soft damp or soft cloth. You need to put it with a mild detergent and clean the device. It's very important that you need to make sure that the device and the hitbox and the pressure transducer, I mean the complete kit, will be dry before you use it for the next patient, okay? Dryness, that means that the device would be ready to use by next patient. Moving forward, as you all aware as well, when we do a hospital sleep lab, we do mainly PSG study, polysomnography study. And when we talk about polysomnography study, we're talking about respiratory sensors, as well we're talking about the neurosensors. So we'll start first with the respiratory sensors. The first one is the cannula. As we all aware, the cannula, it's the disposable part with the device where it has to be replaced after each use. So you use it for a patient, you need to dispose the nasal cannula and have a new one for the next patient. Next one is the thermistor. And as you all aware, thermistor, one of the most important parts of the device that can be affected by COVID-19. And how to disinfect the thermistor, you need to immerse the thermistor or the thermocouple sensor itself. You need to immerse it with Sidex or Omnicide solution. And this has to be within 30 minutes. It has to be for at least 30 minutes. And it's very important to make sure that it has to be dry before you use it for the next patient. However, just in general, to give you information, each hospital sometimes also they have their own protocol for disinfecting their, their equipment, and we need also to follow this. So you have the manufacturer disinfection procedure. At the same time, you have the hospital protocol that can be implemented as well. So next, we'll go for the effort belt, and effort belt, one of the parts that will be adjusted to the chest as well to the abdominal. And in normal situation, you can just clean it with warm water. However, while we are in COVID-19, it's very important to use a special sprays like Amphile, hospital bulk disinfectant cleaner, Decide disinfectant, or Cavicide disinfectant cleaner. And those can be just, you can just spray it on the belt itself, okay? As well as we mentioned previously, it's very important to make sure that the belt should be dry before use it for next patient. Next is the SpO2 sensor. And as you all aware, SpO2 sensors or props, we have it in two options. The first one, which comes as disposable. So you can use it for the patient, then dispose it. And the other option is the reusable. And when we talk about the reusable, then you need to use like a special disinfectant procedure, like you need to get like a cloth, you need to immerse it with, you need to immerse it with mild deodorant, or you need to get a 10% bleach with 90% water. So 10% bleach and 90% water. You need to immerse the, get the cloth, immerse it into this solution, then clean the SpO2 sensor, make sure that it's dry, then use it for the next patient. Okay, so this very important procedure to be implemented. So those are the respiratory sensors. Now we will be talking about the neurosensors. And neurosensors, we mainly talk about the EEG electrodes. EEG electrodes, we have different ways of disinfecting. We have the disinfectant, which is like the Sidex, you can use it. And we have its more stronger sterilization. We have steam sterilization, as well we have ethylene oxide sterilization. So mainly the steam sterilization is the most recommended one. And we have mainly two options. We have the cavity displacement cycle, and we have the pre-vacuum cycles. So when we be talking about the gravity displacement cycle, then you need to steam the gold cup between 10 to 15 minutes at 133 Celsius degree, or 30 minutes at 121 Celsius degree. The second option is to have it between 3 to 4 minutes only at 133 Celsius. In both options, you can follow it by 3 minutes, 133 Celsius as well, just to make sure that it has been disinfected properly. Okay, and those are actually this information. It was published by the grass manufacturer, and you can find it via the below link. Now we'll be talking about the titration device. And as we all aware, the titration device or titration study, it's an important part of the sleep study in general in order to make sure what pressure is required for the patient. So we here talking about a device, we're talking about a tube, and there is some filters which has been connected to the device itself. So when we talk about the device, we have different options. Even you can get a cloth, put it in mild detergent, then swab or clean the device using it, or you can have the 70% alcohol, Decide toilet papers, and even you can get 10% chlorine bleach solution. So you can get a cloth and immerse it into one of these solutions and then clean the device itself. As we all aware as well, we have the filters of the device at the back of the device, and those filters has to be changed every like 6 months. Be sure that the filter will not affect the operation of the device, or it will not prevent like spread the virus, because it's the device, it has one-way valve. So once the patient breathes, even the exhalation will be through the exhalation port or through the mask, so nothing will be back to the device. Another important factor is the tube, and during COVID-19, we highly recommend to use the disposable tubes. No need to use the reusable one. It's better to use the disposable one just to be in the safe side. Okay, another important factor is the mask disinfection. As we are aware, when we use the titration device will be connected to a mask or patient interface. And those masks has to be disinfected after each use. And what we have published here, what you can see here in the picture, you can see like a high-level disinfection procedure for the mask. Based on the mask that you will be using, you have different type of disinfection procedure. You have thermal, chemical, as well autoclave. And it will be shown to you which type of like disinfectant can be used for each mask, as well the maximum cycle can be used. This number here, you can see it 30. That means this mask, for example, can be disinfected for 30 times. After 30 times, you need to dispose the mask. And these are very, very important information. If you would like to get this information, I have the PDF. I can share it with you. Just send me and I will share it with you immediately. Okay, moving forward. Now we finished the discussion about the hospital or in-lab sleep equipment. Now we'll be discussing about the home sleep apnea testing. Now, when we'll be talking about home sleep apnea testing, we don't only talk about the device or the accessories, or I mean the sensors. We talk as well about the carry case itself, because it's a part of the device that will be handed over between people. And it's very important to disinfect those type of carry case. So first, I will start with the device itself, how to disinfect the device. So in general, to disinfect the device, you need to get a cloth, soft cloth. You need to put it in like my detergent. You need to squeeze it to remove the solution from it. Then gently, you can wipe the device, and you can only swab like this part of the device, okay? So you can swab it. You need to make sure that it has to be dry before use it for the next patient. Another option, you can have it with, you can clean the device with isopropyl alcohol 70%, decide, cavicide, and envirocide solutions. So all these can be used. Just you need to get cloth. You need to immerse it with those type of solutions. Make sure, then you can clean the device as well. You need to make sure that the device will be dry before use it for next patient. Next is the carry case. And as I mentioned to you, carry case is very important. Normally we have the hard carry case of the device. And this carry case, it can be considered same like the in-lab equipment, the design of the equipment itself. So you can have as well cloth, soft cloth. You can immerse it in a mild detergent, squeeze it, then clean the outer area of the carry case itself, okay? It's very important. You need to make sure that it's dry even before use it for next patient. Caution or a note, you cannot like use the harsh chemical cleaners. You don't need to use a strong chemical in order to disinfect the carry case. So mild detergent should be much enough for these type of carry cases. Then moving forward to the sensors, as we all aware, when we talk about home sleep apnea testing, we have a little bit less number of sensors. We have nasal cannula. Nasal cannula, same way as the in-lab, it's disposable, so use it, then throw it, and you have to use a new one for the next patient. SpO2 sensor, the same, we have the disposable and we have the reusable, and the same as we have discussed in the in-lab, we can implement it here. And we have the effort belt, the same situation we can use as we have used in the in-hospital sleep lab. So very easy, simple to use. As Professor Bahammam mentioned even earlier, it's highly recommended these days to use the home sleep apnea testing instead of the in-lab in order to prevent the spread of the virus. It's very easy to use, and it can be even sent by courier in order to send it to the patient. Patients don't need to come to the hospital in order even to collect the device. So the last slide of my presentation is just to give you like a general recommendation and guidelines, and which I can see it is the takeaway message of the presentation. The first one is the use of the PPE is mandatory for the sleep technician during sleep diagnostic or titration studies. And this is very important to be implemented. Even if we have a COVID-19 test for the patient, negative test, it's much better. It's recommended to use the BBE kit for the sleep technician. Next, we can utilize the home sleep apnea testing and implement the disinfection cleaning procedure. As we have seen in the previous slides, it's very easy to use. We can send even the information to the patient how to use it. We can attach, for example, a CD along with a device, which can explain all the information how to use the device. At the same time, even all the equipment would be equipped with some pictures on how to connect the sleep apnea device. So it's very easy to use, and it's more safe, especially during these days. even utilizing the local courier provider to avoid patients visiting the hospital. That means patients, they don't need to come to the hospital. We can even send the device from the hospital via the courier to the patient. Patient can use the device, then send it back via the courier to the hospital. So the contact or the face-to-face meetings between patient and technician will be much less. And by this way, we can implement a much better procedures. Important note, according to the AASM, it's highly recommended to conduct sleep study once every 72 hours. That means you will do a sleep study today, tonight. Okay, once you finish, you need to disinfect all the parts of the device. Then you need to do it after 3 days. The next sleep study should be after 3 nights. So it's highly recommended to have enough time between each patient. And the last recommendation is to utilize the telehealth technology. As my colleague Faisal mentioned in the previous presentation, telehealth technology, care orchestrator or others, they are much easy to be used by patient and by technician. They will avoid and at least decrease the interaction or the, I can say, the face-to-face meeting between technician and patient. And that would be the end of my presentation. I'm more than happy to hear any questions from any of the attendees and even to support you after that. Thank you so much.
Thank you, Anas. We have good number of questions, but we'll go with the last presentation by Fatima. So hopefully we are going good with time. So we'll listen to this and then we'll have the panel discussion to answer. We have good number of good questions and hopefully we'll finish as we promised around 10 p.m. Riyadh Saudi time here. So we'll finish on time. So Fatima, maybe you can start your presentation, then we'll take the question to be answered by the panelists.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. My name is Fatma Al-Ahmed and I am a polysomnography technologist. In this video, we will talk about the disinfection of equipment after sleep study. I will divide the video into 2 parts. The first part, we will talk about the disinfection of sleep diagnostic system and its accessories, and the second part will be the disinfection of PAP device and its components. First, we will talk about base station, head box, brusher transducer, and patient cable. Clean the base station, head box, brusher transducer, and communication cable with a soft, damp cloth between use with patients. Make sure all parts are thoroughly dry before using. But be careful. Do not autoclave, gas, or brusher sterilize the diagnostic system, and do not soak or immerse the equipment in any liquid. We will talk about the sensors now, and we will start with the nasal cannula. Important, the cannula is a single use only. After 1 use, dispose the cannula. We should use disposable sensor as much as possible to prevent the spread of disease from one patient to another. Microphone and airflow sensor. Immerse the microphone and thermistor in Sidex and Omnicide solution for 30 minutes. But be careful, do not immerse the other side of the sensors in any solution, as it might damage the head box or the sensor itself. Effort belts. Wash the belts using warm water and household laundry detergent. Rinse them with water again and let them for air dry. There are some safe cleaning products that can be used without degrading the belts or shorten the useful life, such as Amphil Hospital Bulk Disinfectant Cleaner, Dicide, Ultra Disinfectant, and Cavicide. Now we will talk about the SpO2 sensor and oximetry. We have 2 kinds of SpO2 sensor. We have the disposable and reusable. For the disposable SpO2 sensor, it's for single patient use only, so dispose the sensor after the sleep study. For the reusable SpO2 sensors, clean the sensor with a soft wet cloth with a mild detergent or a 10% bleach and 90% water solution. Household bleach contains less than 10% of sodium hypochlorite, so you might need more of that amount with 90% of water. Body position sensor and snap electrodes such as ECG and leg EMG. Clean the sensor with a soft, wet cloth with 70 to 90% of isopropyl alcohol. Gold disc EEG electrodes. Soak in general disinfectant according to the manufacturer's directions after each use. Brush and rinse with warm water, and then you may disinfect them with sodium hypochlorite, Sidex OBA solution, or activated glutaraldehyde such as Sidex and metricide. Now we will talk about the second part of the video, which is the disinfection of positive airway pressure devices. For positive airway pressure device, wipe the outside of the device with a cloth slightly dampened with water and mild detergent. Let the device dry completely before plugging in the power cord. Humidifier. It is recommended in this period to avoid using heated humidifier to prevent any droplet transmission. Heat and moisture exchanger, HME, can be used as a disposable humidification method. If HME is not available and the patient cannot handle PAP therapy without humidity, you may use the heated humidifier. For cleaning the humidifier, empty any remaining water. Wash the water chamber in the sink with warm, soapy water. Rinse well and drain out as much of the water as possible. Let the chamber for air dry before placing it back into the CPAP unit. Tubing. Disposable tubings are preferred to use at this time. Discard them after each use. If disposable tubing are not available, you may use reusable tubing. Gently wash the tubing and mask adapter in a solution of warm water and a liquid soap. Rinse thoroughly and let it for air dry. Do not clean the tubing and mask adapter with bleach, alcohol, solutions containing bleach or alcohol, or solutions containing conditioners or moisturizers, as it may impact the performance of the product. Air inlet filter cleaning and replacing. Clean the gray foam filter at least once every 2 weeks and replace it with a new one every 6 months. The white ultrafine filter is disposable and should be replaced after 30 nights of use or sooner if it appears dirty. Do not clean the ultrafine filter. To conclude, cleaning and disinfection of equipment is a link in the chain of safety and infection control. Disposable and single patient equipment are preferred, especially during COVID-19 pandemic. Always check the manufacturer's instructions as they may differ from one company to another. At the end, stay safe and thank you for watching.
Thank you, Fatima. We will call the panelists now. We thank all the attendees who are still with us. We have a good number of questions. One of the questions that have been asked is about the recording. The recording will be posted on the USDC University Disorder Center official website and also on the University Disorder Center Facebook page. If you put the University Sleep Disorder Center Facebook, the page there, you will have the link to the recording. We have a number of questions here. Would you recommend the same mask used in the study when you do this COVID-19 to be used at home? Anyone would like to handle this? We'll try to answer most of the questions. We have like 15 minutes to cover these questions. Anyone who's Mashni, do you like to handle this question?
Yes, Prof. Actually, regarding the mask, if it's like used in the hospitals or for titration, usually we prefer, to use disposable mask. And but in
I
case
think what they meant to mention that we said it's better to use face mask here to reduce leak, but then the patient may benefit from nasal masks. So, like, should we give that face mask to be taken at home during these days? Not in general, like during these days, or what kind of mask would you recommend?
sometimes we are using its alternatives, especially if the patient has like runny nose or something like a resistance or obstruction. But the face mask is recommended to decrease, the possibility of transmissions. And better it's, but it depends on the compliance of the patient. Some of the patients, they like it more than nasal mask.
Yeah. I mean, I think that these are difficult days. I know someone else has a comment. Mariam and Twitter, they keep quiet. This is a difficult time because we say use face mask, non-vented, if you can, to avoid aerosol, reduce aerosol. Then at home, what should they use? I think probably we don't have to use that mask exactly at home. Maybe in the clinic, we can try masks without using CPAP, see which one they feel comfortable with. And if they feel comfortable with nasal mask, probably this can be prescribed for them at home. But the recommendation is don't use CPAP in the clinic because aerosol will come there, especially use nasal mask will be around. So maybe just you can try different masks without positive airway pressure and see which one they will like. There is a question, should we do COVID-19 screening for patients who will go for home sleep apnea testing? Again, this is a tough question. Patient, if you are not going to have to be in contact with them, then no need to ask them for COVID-19 testing. If you are going to go to their house and titrate for them CPAP in the house, do the titration yourself, go and connect, then you should take the same precautions that we recommended for in-lab titration, because you have aerosol around. However, if the patient you teach them, and it's easy how to fix the mask, and there are a lot of educational videos on YouTube, and the patient will do it in his own. Just he will receive the device, he will connect that. The device is already set, just he has to connect the mask and put the device on. Then I think there is no need, but you should advise the patient to do the titration in a single room, no one else with him. So he will not like spread the aerosol to the others during the titration. If he is asymptomatic, we don't have to screen them. But if you will do it yourself as a staff, then we will have to take the same precautions that are taken in the hospital. There's a question here about, I don't know who will handle this, maybe Dr. Raouf, ideal staff-patient ratio during COVID-19. Raouf, are you with us?
Yes, I'm here, Prof. During these times of COVID-19 times, we have to practice staff rationing. Staff rationing is basically, there are two things we have to achieve. One is that we have to make sure that we allow our staff to work for any quarantine deficit or any sickness deficit. Second thing is to have a minimum exposure of the staff. In this regard, we have to usually follow the hospital guidelines, where hospitals or the ministry, which is taking care of these rules, that we have to arrange staff accordingly. In most of the hospitals right now, they recommend half the staff or around the 66% staff attendance in the centers. And we have to work accordingly. Like there has to be staff rationing for any emergency or any contingency plans also.
Okay. And this question, maybe Dr. Faisal, if you like to answer, then probably I will comment. They ask, is it only Philips that has telemonitoring?
No, not only Philips. There are other manufacturers who have telemonitoring solutions. The question is more on the deployment of telemonitoring solutions in the countries. So this is pending also to some legal and regulatory aspects on each country. So there are regulations in different countries before implementing a telemedicine approach. But so to answer to the question, there are other companies that are providing telemonitoring solutions as well.
Okay, very good. You know that for data to go from CPAP to a server, some countries, if this server that will collect data from patient CPAP machines, if this server is outside the country, then in some countries there are regulation does not allow sharing data of their patient outside the country, like Saudi Arabia, for example. That's why they have to get approval from the authorities. Like in Saudi Arabia, we have the Saudi FDA. With that, then the companies are working on that. So it has some problems still. Engineer Anas, there is a question, very good question. They said, is like when you disinfect the devices, then you say you don't use it for 72 hours. Then where will you store it? These 72 hours, or anyone else can answer. Where will you store it for the 72 hours until you can use it again?
Good question. Good question. And normally, most of the sleep labs, when they have the sleep apnea devices like the Headbox base station, even they have a dedicated place in the patient room itself, or they have like a cabinet where they store the sleep equipment. However, we don't recommend that they, for example, disconnect all the equipment, save it in cabinet, then reconnect it again. It's better to keep the units connected. And as long as the sleep patient room is not utilized by other patients, nothing will happen to the device. So even keeping the device disinfected, cover it, and maybe they can even disinfect the device prior the patient can arrive to the hospital, just to be in the safe side as well. But I mean, as a specific storage, there is no specific storage. They can even keep it at the patient room or have it in a specific location in the sleep lab.
Okay. There is a question about how to control infection from staff to patients. I think Dr. Raouf in his lecture, he discussed that staff should have screening daily, like a questionnaire screening daily, probably at the morning and evening, and they should be encouraged to report if they have any symptoms, should be encouraged like to stay at home, not to come. And if there is any risk of contact or something, then they should go through the same quarantine that is done for everyone. And infection between staff and staff, it's encouraged during these days that staff should not interact much with each other, and people working in a unit shouldn't go wandering in other units that they don't work. And for example, you are working in the sleep disorder center, go to your work, then from that place, go to your car, go home. Don't go to visit your friends, for example, in the echocardiography or in this and that. Don't socialize these days with your friends in the hospital. This will be a way to reduce infection. Engineer, there is another question. Say, how to clean EEG leads if we don't have the sanitization methods that you mentioned?
Yes. Even we have another option, which is the disinfection procedure. If we don't have sterilization, we have the disinfection procedure, which immersing the gold cup into a Sidex. So you can have the Sidex solution. You can immerse the gold cup into the Sidex for 30 minutes, then make it dry, then save it or store it properly. So that's, and I believe Sidex is available in most of the hospitals.
Okay, and there is a question here. Raouf, you have been working with the COVID-19 team or to anyone of the team, which is a very important question. They say, how about disinfecting chairs, waiting areas, patient room, beds, doors, knobs? All these are important, which is done in the hospital, because it's not only for the sleep center, it's even for the patient room. So do you know how they are doing it in the hospital?
For all these equipments like bed posts, tables, we have to follow the infection control guidelines of the hospital. Usually in the hospital, they use alcohol dabbed cloth or alcohol sprays for counters, for bed posts and other places, which is done in routine. But it's always advisable to follow the infection control guidelines of the hospital.
Very good, very good. Fatma, there is a question. They say you should use gloves. Then they say, should we dispose these gloves after usage, after cleaning the equipment?
You may use reusable or disposable. For disposable, we use at the center gauze, only 4x4 gauze, and we sterilize it with alcohol or bleach.
Okay, okay. And something you mentioned here that solution after cleaning with Sidex. This is for thermistor. Do we have to use alcohol solution after cleaning with Sidex? Fatima?
No need for that procedure as it will disinfect by the Sidex.
Okay, and there is also one question for you. There's you said that the other side of thermistor should not be immersed in sanitizer to avoid damage. You said this is not clear. What do you mean by that exactly?
The other end is not in a direct contact with the patient. So maybe if you can just wipe it with alcohol, that might do the work.
Okay. And there is a question here, say for the portable study, is it recommended to wait for 72 hours before the next study? For the equipment has to wait, but if you have like 2-3 equipments, you will do one every night, that's fine. You like 3 equipment, each night will go with one patient. But for that device, it's recommended now to wait for 72 hours. There is a question here, say, what can you say about the use of HEPA filter during in-lab testing and ultraviolet light is effective as disinfectant after sleep test? I think we talk about the HEPA filter, and this has been discussed even for in our hospital. They say it is not, if other precautions probably do not need it. If the patient has infection overnight risk or waiting for the result, probably go for room. But I don't understand the question about the ultraviolet light. About the record, if you go to University Sleep Disorders Center, you will have the page and you will have the link there, so you can get it. We cannot email it to all the attendees because we have a good number of attendees, difficult to be in touch with all of them. This is my question was patient to staff ratio. The American Academy of Sleep Medicine recommend 1 technician for 2 patients. The European, they say up to 1 technician for 4 patients. But I think during COVID-19 should be 1 patient, 1 technician, because you want to minimize the interaction between persons. During these days, we should be 1 technician, 1 patient. So to avoid, like, if 1 patient has infection, then the technician will move it to the other one. So probably it's recommended now 1-to-1 should be the best. When can we say BSG is emergency procedure and should be done urgently? Do you want to handle that, Raouf?
Yes, of course, Prof. This is basically a physician-based decision. A physician will evaluate the patient, look at the pros and cons of doing a sleep study. Usual emergency cases which we come across are patients who have sleep disorder breathing, like OHS, or patients who retain CO2. They are considered as emergent cases for this sleep studies. Then there are semi-emergent cases, where we have cases like narcolepsy, patients of RBD who are at risk of injuring themselves or their bed partners. These are considered as semi-emergent. But for emergent, it is basically OHS patients who are critically ill.
Okay, there is a question here. Can we start treatment empirically based on clinician assessment without BSG? If we talk, for example, about patients who come with acute respiratory failure, mainly acute hypercapnic respiratory failure, patients with obesity, hypoventilation, and decompensated respiratory failure, yes, the recommendation of the American Thoracic Society that you should start blind treatment with bi-level positive airway pressure and then discharge them home on that device and plan for a sleep study within 3 months. About patients with obstructive sleep apnea, usually they are chronic patients and they have been symptomatic for a long time. So it's recommended that you go with home sleep apnea testing to confirm the diagnosis severity and go for an attended titration. But patients who are admitted to the hospital sick, yes, you can start blind non-invasive ventilation therapy. Then when they are more stable, like within 3 months, you can probably do the sleep study. This question comes again from our friend who was asking this, probably we don't answer. Can we use ultraviolet light to disinfect the room in the morning after every BSG? Does anyone have an answer for this? Dr. Faisal, do you know anything about this?
No, I don't, unfortunately.
Anyone has any idea about using ultraviolet to clean the room? Because
if we
yes,
look at the American Academy of Sleep Medicine guidelines, and if we look at CDC
raise your voice.
or CDC guidelines and AASM guidelines, they have not mentioned use of ultraviolet rays anywhere. If we look at European guidelines or even in Canadian, it's not mentioned anywhere.
Okay, because the rooms usually in the hospitals, like they have a routine, each hospital, and they clean it as Dr. Rauf mentioned on previous things. This is a question that I don't know if you, Anas, want to take this, how to clean the ventilator's screen and surface.
If we're talking about the screen itself of the ventilator, we may consider it similar to the situation of the device itself. So we can have mild deterrent with, we can bring even a soft cloth and clean it through that. However, we have already also published general specific disinfection guidelines for ventilators. So if someone is interested for that, I can share it with him as well.
Okay. Okay, the question here about the ratio again that the American Academy say 2:1. In COVID-19, there are no official recommendation by any society or body now, but it makes sense to be one patient and one technician to avoid interaction, but there are no recommendations now that I'm aware of. And the comment again about the ultraviolet, I think some of our attendees, they have experience with that. They say, oh, this is a question, can we use the cabinet with the ultraviolet lamp for the storage of the patient equipment? Can we use a cabinet with ultraviolet lamp for the storage of patient equipment? Do you have any idea, Anas, on that? Do you have anything?
No, doctor, actually, I have no
Dr.
confirmed
Faisal,
information.
anyone has anything? Okay, probably we don't know. How about MSLT in this pandemic? Yes, MSLT is less urgent these days, except for cases that are equivocal. If you have a patient with clear narcolepsy, cataplexy, I would recommend that we start treatment these days. No need for a sleep study, and then do sleep study when we have better situation. But these days, probably, I got some fresh narcoleptic patients during this COVID-19 patient with narcolepsy. We started them on treatment if they have clear diagnostic criteria, clinical, you can diagnose them. We try to with that. Okay, the slide. Okay, any slides or soft copy of this webinar? We'll try to have the whole webinar free online, as we said, through the USDC Facebook and USDC official website. Can you explain about prediction algorithm in home sleep apnea testing? I don't know what's meant by prediction algorithm, but home sleep apnea testing is recommended for patients with moderate to high likelihood of obstructive sleep apnea, assessed by a physician. And then you do sleep study one night. You find that they have OSA, they need treatment, they are symptomatic. You start the unattended titration. You start with the auto CPAP. Probably you can keep like from 4 to 20, and then leave the device with the patient for a few days. There is no agreement on how many days in different studies, but most randomized trial that used unattended are compared with in-lab titration, they use around 3 nights. So maybe 3 nights, some people use it 7 weeks, depending on how busy is your center, how much you can afford. But probably 3 nights are enough to use it. Then take the data, download it, see what's the B90 as Dr. Faisal mentioned, make sure there is no leak, patient is comfortable after the device when you talk to them through the virtual clinic. If they are comfortable, what's the P90? Then probably if you like to give them conventional CPAP because it's cheaper, it's fine. You can prescribe it based on the auto CPAP. You don't have to give auto after that. You can give them conventional based on the findings. We are almost 10 and we promised to stop at 10. We still have a good number of attendees with us. We thank them all for staying all this time. We thank all the panelists and speakers for being with us. I hope that this workshop was useful. It came quickly because it's well needed at this time when everything is reopening in most of the countries. It's good to have some idea about what to do next. The webinar will be available hopefully by tomorrow on the USDC Facebook page. If you go to the Facebook, just write University Sleep Disorders Center. It will be the only page that will appear to you. Also, it's good that if you join, follow that page because we got a lot of educational material in that page. You can, then you will have the full webinar there. I thank you again. Any comments from the panelists? Do you want to conclude with any comments, anyone? Dr. Faisal, you want to say anything?
No, I would like to thank the audience for staying and for the relevant questions, and I would like to thank you, Professor Bahammam, for inviting us and giving us the opportunity to participate in this excellent webinar.
Thank you very much, and hopefully we'll be in touch again in other webinars. We are now more familiar with the online webinars and workshops. Thank you and see you soon. Thank you all. Bye.
Thank you very much.
Goodbye.